When someone suffers a stroke, we generally know what to expect from the physical fallout.
Right, the obvious motor deficits.
Yeah, exactly. A weakened arm, a sudden inability to balance, perhaps slurred speech or a drooping face. These are the classic, really terrifying hallmarks of a vascular event in the brain.
Absolutely. It's what everyone looks for.
But what if the only noticeable symptom of a stroke was an uncontrollable, sudden urge to tell pointless, inappropriate jokes?
Yeah, which sounds bizarre, but it happens.
Or what if a previously vibrant, ambitious person survived the stroke physically completely intact, but plunged into a deep, unshakable apathy, like where they simply stared at a wall, completely devoid of the desire to move or speak?
It's devastating.
Yeah.
And it really challenges our whole perspective.
It does, and the physical damage to the brain is one thing. But today, in this deep dive, we're exploring a far more complex reality. We are looking at how a disruption in blood flow can completely rewrite a human personality.
It is genuinely one of the most profound phenomena in all of medicine. I mean, we are talking about the exact moment when the biological plumbing of the brain fails and the psychological self shatters as a direct result.
Which is heavy, but so important to understand.
It is, because psychiatry, at its absolute core, and this is a great anchor for you listening today, psychiatry is the study of how the brain, the mind, and human experience interact.
Right.
And more importantly for clinicians, is the study of how that intricate process goes wrong. When we look at cerebrovascular disorders, conditions that restrict or alter blood flow to the brain, we are forced to confront a really stark reality.
That the mind isn't just floating around in the ether.
Exactly. The mind is not some ethereal entity floating above the body. It is fundamentally entirely sustained by physiology.
I think to really grasp the scale of this, we need a mental model. Imagine a bustling, vastly complex metropolis, millions of people, thousands of streets, endless streams of data and energy moving in perfect orchestrated synchrony.
I love this analogy.
Right. So this city is your brain. And sustaining this incredible urban sprawl is a vast, intricate network of rivers and canals, which is the cerebrovascular system. Now, think about what happens when a massive dam abruptly bursts.
Which would be a hemorrhage.
Spot on. That is a hemorrhagic stroke. Or imagine when a vital supply canal is completely blocked by a buildup of debris, starving a whole district of resources.
And that is an ischemic event.
Exactly. Now, the immediate physical damage to the buildings in that analogy is totally obvious.
Yeah, in our brain metropolis, the collapsed bridges and flooded neighborhoods, they translate to the sudden motor deficits or sensory loss we mentioned earlier.
The paralysis.
Right. But the true profound effect of these vascular disasters isn't just the structural damage to the concrete. It is how the entire culture of the city changes in the aftermath.
Oh, that's a brilliant way to put it.
When the infrastructure fails, the actual life of the city fundamentally alters.
So the markets might suddenly stop trading, which we see in the clinic as profound, paralyzing apathy.
Yes, exactly.
Or the artists and musicians might become deeply melancholic, mirroring post-stroke depression. Or, in some of the most striking cases, you might see sudden riots breaking out in previously quiet, peaceful neighborhoods.
Which perfectly encapsulates the catastrophic emotional reactions and sudden irritability we see in stroke survivors.
And we have to place this within the context of the sheer, staggering scale of the burden. Like, we are not talking about a rare neurological curiosity here.
No, not at all. We're looking at a modern public health crisis of monumental proportions. The World Health Organization estimates that 15 million people globally are diagnosed with a stroke each year.
15 million. That's a staggering number.
It is, and it remains the second leading cause of death worldwide.
Now, when most people think of a stroke, they naturally picture an elderly relative. And, the data backs that up to an extent, right?
It does, yes. The incidence of a first stroke is greatest in those aged 85 or older. They make up about 17% of all stroke patients.
But there is a statistic in the literature that completely shifted my perspective when we were preparing for this deep dive. Approximately 10% of all strokes occur in individuals aged between 18 and 50.
Yeah, it's a sobering reality.
Huh.
1 in 10 strokes is happening to people who are in the prime of their careers.
Right, people who might be raising toddlers or just starting their adult lives.
Exactly. And the trajectory for the future is genuinely alarming. If we look at the period between 2010 and 2050, epidemiological models suggest the number of incident strokes is expected to more than double.
Wow, double.
Yes. This increase will be heavily concentrated among older adults, specifically those over 75, and within minority groups who often face really systemic disparities in vascular healthcare.
So because medical science is getting better at keeping people alive through the acute physical crisis of a stroke, which is great, we are inadvertently creating a massive secondary crisis.
That's exactly what's happening.
This isn't solely a neurological issue of tissue damage and physical rehabilitation anymore. It is a looming neuropsychiatric tidal wave.
It really is. As more people survive these vascular events, clinicians across the globe are going to be faced with the behavioral, cognitive, and emotional aftermath.
Which is why understanding this intersection of vascular disease and psychiatry is no longer optional for anyone in the medical field.
Right. The behavioral changes aren't just psychological reactions to being sick. That's crucial to understand. They are primary symptoms of the brain injury itself.
I want to look at how we arrived at this understanding. We are so accustomed to modern neuroimaging. Like if someone has a behavioral change today, we just slide them into an MRI machine.
We look at the functional connectivity and point to the gray matter.
Yeah. But long before fMRI or even basic CT scans existed, early clinicians were intuitively grasping this mind-brain connection through sheer observation.
The history here is incredibly rich. In the early 1900s, the psychiatric establishment was deeply divided.
How so?
Well, on one side, you had a push towards extreme biological determinism, almost reminiscent of phrenology.
The idea that you could map complex moral traits to specific square inches of the skull.
Exactly. And on the other side, you had the emerging psychoanalytic movement that viewed many psychiatric conditions through a purely psychological lens.
And right in the middle of that tension, you have figures like Adolf Meyer.
Yes, Meyer.
Yeah.
He was the preeminent psychiatrist in America during the early 20th century.
What was his approach to this? Because it seems like a minefield.
Meyer was remarkably balanced. He championed a deeply biopsychosocial view of mental reactions, long before that term became a buzzword. He explicitly warned his peers against overly hasty, rigid localization.
He didn't believe you could point to a single gyrus and say, here lies human sadness.
Right. However, despite that caution, Meyer recognized through rigorous clinical observation that specific syndromes like profound delirium, cognitive dementia, and aphasia were the direct, undeniable result of physical brain injury.
So he saw the connection.
He did. He observed that conditions resembling manic depressive illness or paranoid states often arose from a combination of direct brain injury, specifically citing the left frontal lobe, interacting with the patient's premorbid personality and family history.
He was seeing the network effects before he had the vocabulary for networks.
Precisely. And across the Atlantic, you had Emil Kraepelin. He is arguably the father of modern psychiatric classification.
Kraepelin was a meticulous observer of the natural history of mental illness, right?
He was. And he recognized a very clear association between manic depressive insanity and cerebrovascular disease. He specifically noted in his writings that diagnosing states of depression becomes incredibly murky and difficult when arteriosclerosis is involved.
That's the hardening and narrowing of the brain's arteries.
Exactly. He saw that vascular disease could mimic or perhaps directly cause the profound mood swings he was categorizing.
And Eugen Bleuler, the man who coined the term schizophrenia, also weighed in on this, didn't he?
He did. Bleuler explicitly described what he called melancholic moods lasting for months that appeared with striking frequency in patients after they had suffered strokes.
So these early titans of psychiatry were all independently noticing that when the blood supply to the brain is compromised, the psychiatric presentation shifts dramatically.
Yes. The clinical descriptions from that era are fascinating because they didn't have the sterile, highly operationalized language of the modern DSM.
They used descriptive nomenclature that painted such a vivid picture of the patient in the room.
They really did.
There are two conditions discovered back then that perfectly illustrate how specific vascular injuries cause bizarre psychiatric symptoms. The first one involves Leonore Welt in the late 19th century, and later Hermann Oppenheim.
Ah, yes. You are referring to the discovery of Witzelsucht.
Witzelsucht.
Such a great word.
It is a German term that translates roughly to a joking addiction or wisecracking disease.
Wisecracking disease. Wilt and Oppenheim observed patients who, following specific brain injuries, developed an inappropriate, uncontrollable drive to make puns, tell pointless stories, or make crude jokes at highly inappropriate times.
And this wasn't just like a coping mechanism for the trauma?
No, not at all. It was accompanied by an empty euphoria and loquaciousness.
Yeah.
I mean, they simply could not stop talking.
And they managed to localize this without modern imaging.
Yes. Through postmortem examinations and meticulous neurological exams, they correctly associated this highly specific behavioral change with injury to the orbital frontal cortex.
Which is the area of the brain sitting right above the eyes.
Right. It was such a profound finding that later neuroanatomists like Carl Kleist went so far as to state that the orbital frontal cortex must be the very center of emotional life and ego.
It is wild to think about. A blood vessel bursts above your eye and suddenly your brain's filter is just gone, leaving you constantly making inappropriate jokes at a funeral.
It's a stark reminder of our biology.
It really is. Now, the second historical phenomenon I want to discuss is from 1952, described by Derek Denny Brown. He called it the indifference reaction.
Denny Brown observed a distinct pattern in patients who had suffered lesions, specifically in the right hemisphere of the brain.
What did that look like clinically?
Well, these patients would demonstrate a chillingly complete lack of interest in their family and friends. They showed a profound indifference toward their own physical failures or paralysis, a tendency to enjoy foolish, shallow jokes, and a bizarre minimization of their immense physical difficulties.
It's as if the stroke literally deleted their capacity for concern. Not just concern for others, but basic evolutionary concern for their own survival.
Yeah.
Like, they are paralyzed on one side of their body and they simply do not care.
Precisely. And this historical grounding brings us directly into the modern nosological dilemma.
Nosology being the branch of medical science dealing with the classification of diseases.
Yes. If we accept what Meyer Kraepelin and Denny Brown saw, that brain lesions cause psychiatric syndromes, how do we classify that today?
Right, because if I look at the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, the DSM-5, it takes a very specific, somewhat controversial stance on this.
It does. It defines post-stroke psychotic, mood, and anxiety disorders under a broad umbrella called disorders due to another medical condition.
So if a patient meets the full criteria for a major depressive episode after a stroke, their official diagnosis is depressive disorder due to stroke, with major depressive-like episode.
That is the current framework. The DSM tries to draw a hard line connecting the medical etiology, the stroke, to the psychiatric presentation.
Okay, but I really have to challenge this framework because it feels incredibly disconnected from the reality of clinical practice.
I completely agree.
Like if a 55-year-old patient has just suffered a massive stroke, they might have lost the ability to walk. They might have aphasia and struggle to speak to their spouse. They have likely lost their ability to work in their chosen profession. Their entire identity has been fractured.
It's a massive life trauma.
Exactly. So how can any clinician, even the most experienced psychiatrist in the world, look at that survivor and definitively say, your depression is a direct physiological result of the ischemic dead tissue in your left frontal lobe, and not just a completely understandable, profound psychological reaction to losing your independence?
It's incredibly difficult.
How are we supposed to untangle the neurobiology of a lesion from the deep human psychology of grief?
That is the ultimate diagnostic tightrope. You have hit on the fundamental challenge that has plagued clinical investigators for decades when diagnosing depression in the presence of severe physical illness.
How do you attribute symptoms?
Exactly. Because core depressive symptoms like weight loss, profound fatigue, psychomotor retardation, or severe insomnia could certainly be caused by the primary psychiatric depression.
Sure.
But they could just as easily be caused by the physiological stress of the stroke, the hospitalization, the physical therapy, or the sheer exhaustion of having a damaged central nervous system.
It seems like a guessing game. How has the psychiatric field historically tried to solve this overlap?
Historically, clinicians and researchers have debated 4 distinct approaches to solving this symptom overlap problem. It is worth looking at them to understand how complex this is.
Let's go through them.
First, there is the inclusive approach. In this method, the clinician casts a wide net. You simply count all depressive diagnostic symptoms present in the patient, regardless of whether they might be related to the physical illness.
So if they are tired, you count it. If they're losing weight, you count it.
Exactly.
The problem there seems obvious. You are going to overdiagnose depression in almost every stroke patient because every stroke patient is going to be tired and have changes in appetite.
Exactly. It lacks specificity completely. So the second method is the etiologic approach. This is essentially the opposite.
How does that work?
A depressive symptom is counted towards the diagnosis only if the clinician feels highly confident that it is not caused by the physical illness. Importantly, this is the method the DSM-5 technically requires clinicians to use when making these diagnoses.
Which brings us back to my frustration. The etiologic approach demands that the clinician act as a mind reader and a cellular physiologist simultaneously.
Yes, it really does.
You have to look at a fatigued patient and declare, this fatigue is 100% emotional, not physical. That seems nearly impossible to execute perfectly.
It relies heavily on subjective clinical judgment, which means two different psychiatrists might look at the same patient and give two different diagnoses based on their personal bias.
That's a huge problem for research and treatment.
It is. So, to bypass that subjectivity, a third method was proposed, the substitutive approach.
Okay, what is the substitutive approach?
This approach attempts to remove the ambiguous physical symptoms entirely. You take the neurovegetative symptoms, like sleep disturbances, appetite changes, and fatigue off the table.
And replace them with something else.
Yes. To make up for their absence in the diagnostic criteria, you substitute them with additional cognitive or psychological symptoms of depression, like excessive guilt, worklessness, or suicidal ideation.
That feels a bit like moving the goalposts just to make the diagnosis cleaner.
It absolutely does alter the fundamental construct of what depression is.
Mm.
And finally, the fourth method is the exclusive approach.
All right, what does exclusive mean here?
Here, you entirely remove any symptoms from the diagnostic criteria if those symptoms are not found to be more frequent in depressed stroke patients compared to non-depressed stroke patients. You only look at the symptoms that clearly separate the two groups.
So we have 4 different methodologies, all trying to solve the exact same problem. How did the field actually resolve this? Because we can't have a diagnostic system where the rules change depending on which hospital you walk into.
No, we can't. The resolution required rigorous, empirical, large-scale studies. We had to stop guessing and look at the actual phenomenology.
Oh, great.
The breakthrough came through work by Sergio Paradiso and his colleagues in 1997, and was later strongly supported by Cumming and colleagues in 2010. Paradiso evaluated over 100 patients longitudinally, following them up to 2 years after their stroke.
What were they looking for specifically in those 2 years?
They meticulously divided all reported depressive symptoms into 2 categories. Vegetative symptoms, things like autonomic anxiety, disrupted sleep, or subjective energy, which is a profound lack of energy.
And the second category?
Psychological symptoms like excessive worrying, feelings of worthlessness, or hopelessness. They then compared the frequency of these symptoms between stroke patients who appeared depressed and stroke patients who did not.
And what did the data show? Did the physical symptoms muddy the waters like everyone feared?
Actually, the findings were revelatory. What Paradiso found was that the vast majority of both vegetative and psychological symptoms were significantly more frequent in the depressed stroke patients compared to the non-depressed stroke patients. Yes, and this held true across nearly all follow-up intervals over the 2 years.
Wait, so the non-depressed stroke patients weren't just uniformly exhausted and losing weight because of the stroke?
No, they weren't. The physical symptoms of depression clustered tightly with the psychological symptoms of depression, even in the presence of severe brain injury.
That's fascinating.
Cummings' 2010 study took this a step further. They confirmed Paradiso's findings by comparing the symptom profiles of depressed stroke patients with depressed individuals from the general population who had never had a stroke.
That is the ultimate test, isn't it? Does post-stroke depression look like primary major depressive disorder?
Exactly. They ran a complex factor analysis of 10 psychological and somatic symptoms. The results showed absolutely no difference in the factor structure between the stroke group and the control group.
Wow.
The phenomenology of post-stroke depression, or PSD, is remarkably fundamentally similar to general primary depression.
So whether we are talking about the physical symptoms like low energy and insomnia, or the cognitive symptoms like debilitating guilt and suicidal ideation, a stroke patient with depression looks clinically identical to a perfectly physically healthy person with major depressive disorder.
The syndrome is the same.
It is the exact same syndrome. Which leads clinical researchers to a very compelling argument about how we classify this. Because the clinical manifestations are essentially identical, many experts argue that the DSM-5's due to another medical condition label is clumsy and perhaps inaccurate.
Right, because it implies the depression is somehow secondary or other than real depression.
Exactly.
The literature suggests that making stroke a specifier would be far more clinically accurate and empirically supported.
Make it a specifier, like how?
Well, Think about how we diagnose depression related to childbirth. We don't say depressive disorder due to pregnancy. We diagnose major depressive disorder, and we add the specifier with peripartum onset.
Oh, right. It acknowledges the physiological trigger without invalidating the primary psychiatric nature of the illness.
Exactly. Using a with post-stroke onset specifier would relieve the clinician from playing that impossible guessing game about exactly which symptom belongs to the tissue damage and which belongs to the psychological trauma. It treats the depression as a primary reality.
That is a massive paradigm shift in how we think about this. It elevates the vascular event from just being a medical backdrop to being a core integrated component of the psychiatric diagnosis.
It does.
But if the symptoms of post-stroke depression look exactly the same as primary psychiatric illnesses, I really want to know what is actually happening in the biological wiring of the brain to cause them.
The mechanism.
Right. If the plumbing fails, why does the mind break in this specific way? Let's dive into the mechanisms and models.
To understand the mechanisms, we have to fundamentally shift how we view the brain.
Yeah.
We have to move beyond simple geography.
Okay, what do you mean by that?
A core rule to anchor onto here is that specific clinical symptoms are rarely the product of an isolated tiny lesion acting alone. We're not dealing with phrenology. Symptoms are the result of the dysfunction of key neurocircuitry. The brain operates in vast interconnected networks.
So it's less about a single building collapsing in our metropolis and more about the power grid being severed.
That's a perfect way to look at it.
And the nature of the vascular event, the type of stroke, dictates how that grid is damaged, right?
Yes, the etiology of the stroke matters. Cerebrovascular disorders interrupt the blood supply, but the mechanism of that interruption varies. Nearly 90% of strokes are ischemic.
Meaning a blockage.
Right. This means there is a total or partial absence of blood flow, usually due to a thrombotic clot that forms locally, or an embolic clot that travels from the heart and lodges in the brain. The tissue simply starves of oxygen and glucose.
And the other 10%?
The remaining 10% are hemorrhagic strokes. This is when a weakened blood vessel ruptures, leading directly into the brain parenchyma or the surrounding subarachnoid space.
And those are usually more severe acutely.
They are violently destructive. The pooling blood creates immense intracranial pressure, physically crushing adjacent tissue, and the blood itself is highly toxic to neurons. They carry a much higher acute mortality rate.
We also classify these events by the size of the plumbing involved, don't we? Like large vessels versus small vessels.
Correct. Large artery disease, like a blockage in the middle cerebral artery, produces large, sweeping cortical lesions. It wipes out entire districts of the brain.
And small vessel.
In contrast, small arteriolar disease affects the tiny, hair-thin, penetrating vessels deep inside the brain. When these block, they result in small, deep lacunar lesions. There are tiny pockets of dead tissue in the white matter, or deep structures like the basal ganglia.
But here's the critical point regarding neuropsychiatry, isn't it? Whether it's a massive cortical infarct from a large artery or a microscopic lacunar stroke deep in the white matter, if that lesion hits a critical node or pathway in a neural network, you will see profound psychiatric symptoms.
Yes. A tiny cut in the right wire can bring down the whole system.
So let's apply that network theory to post-stroke depression. We know the prevalence is massive. We know it looks like primary depression. What is actually happening on a cellular and chemical level?
The etiology of PSD is not a single pathway. It is a cascade of biological disasters. We look at several interacting hypotheses.
Okay, what's the first one?
First, there is the direct anatomical disruption. A stroke can physically sever the ascending pathways that distribute biogenic amines. These are the tracts projecting from the brainstem that bathe the cortex in serotonin, norepinephrine, and dopamine.
Oh, wow.
If the tracts are cut by a lesion, the frontal lobes are suddenly starved of these vital mood-regulating neurotransmitters.
So you have a literal chemical drought because the delivery highways are destroyed. What else is happening?
We also look at genetic vulnerabilities. There is evidence linking serotonin transporter gene abnormalities to a higher susceptibility for PSD.
So some people are just genetically more at risk when the stroke happens.
Exactly. But perhaps the most intense area of current research is the inflammatory response. A stroke is not just a loss of blood. It is a massive, catastrophic inflammatory event in the central nervous system.
How does inflammation cause depression? Because, I think most people understand inflammation as a swollen ankle, but how does it work in the brain?
When brain tissue dies, it triggers an immune alarm. Microglia, the brain's resident immune cells, become hyperactivated.
And what do they do?
They release a storm of pro-inflammatory cytokines, particularly interleukins like IL-6 and IL-18, as well as tumor necrosis factor alpha.
TNF-alpha.
Right. These cytokines don't just clear dead tissue. They actively interfere with neurotransmitter synthesis. They can alter the way serotonin is produced and metabolized, effectively plunging the brain into a depressive state.
It's incredible to think of the immune system actively suppressing mood.
It really is a fascinating crossover between immunology and psychiatry.
And on top of that, the stroke is a terrifying psychological and physical trauma. Does the stress response play a role?
A massive role. The sheer terror and physiological shock of the event severely dysregulates the hypothalamic pituitary adrenal, or HPA, axis.
Which produces cortisol.
Yes. This leads to wildly elevated levels of glucocorticoids, specifically cortisol. Chronic high levels of cortisol are neurotoxic. They specifically disrupt glutamate transmission, which is the brain's primary excitatory neurotransmitter, and they can cause actual atrophy in structures like the hippocampus, which is vital for emotion and memory.
It is a toxic soup. You have severed amine highways, a storm of inflammatory cytokines, and a flood of neurotoxic stress hormones. That perfectly explains the how.
Yes.
But the where must matter too. I really want to talk about lesion location because trying to follow the research on this over the last few decades is, well, it's enough to give anyone whiplash.
Oh, absolutely. The medical community has gone back and forth on this multiple times.
It is arguably one of the most hotly debated, fiercely contested topics in neuropsychiatry. Let's trace the evidence chronologically because it shows how science iterates.
Let's do it. In the 1980s and 90s, the early meta-analyses were driven largely by Robert Robinson and his colleagues. They focused intensely on the acute phase, the first few months post-stroke.
And what did Robinson find? Because his findings became almost medical dogma for a while, didn't they?
They did. Robinson's group found a very strong, highly specific association between post-stroke depression and left anterior strokes.
Left anterior.
Yes. Specifically, a stroke in the front left portion of the brain increased the odds for PSD by more than double compared to strokes in the posterior regions or the right hemisphere.
That's a huge increase.
It was so specific that they even reported a significant inverse relationship between the severity of the depression and the distance of the stroke from the frontal pole.
Meaning, the closer the dead tissue was to the absolute front of the left hemisphere, the more profoundly depressed the patient was.
Exactly. It was a beautiful, elegant correlation.
Okay, so mystery solved. Left frontal lobe equals depression. Why is this a debate?
Because in science, elegant theories must survive replication. And a few decades later, a much larger meta-analysis cast serious doubt on Robinson's rule.
What happened?
A study by Nawe and colleagues reviewed 43 studies encompassing over 5,500 patients. They applied rigorous modern statistical models, and they found absolutely no overall consistent relationship between lesion location and PSD.
Wait, none at all, after Robinson showed such a clear gradient.
None overall. However, Wai's group didn't just stop there. They ran complex subgroup analyses, looking specifically at the timing of the assessments.
Okay, and what did the timing reveal?
They found a fascinating wrinkle. While there was no overall left hemisphere dominance, they did find a modest but statistically significant link between right hemispheric strokes and PSD risk, specifically within the subacute phase, which is roughly 1 to 6 months post-stroke.
So Robinson says left anterior is the primary driver. Weiss says there's no overall relation, but if anything, the right hemisphere is riskier in the subacute phase.
Right.
How is a clinician supposed to make sense of this? It sounds like the data is completely contradictory.
To resolve this, we looked at the most recent massive syntheses of the data. The fourth major meta-analysis by Dovin and colleagues took a wider view, including 74 studies.
And what did that show?
This massive review helped clarify the noise. It confirmed a clear, significant, enduring risk of PSD associated with lesions, specifically in the frontal lobes and the basal ganglia, regardless of which side they were on.
Okay, so synthesizing Robinson, Way, and Duvin, what is the actual clinical truth? How do you apply this when looking at a patient's CT scan?
The synthesis suggests two critical principles. First, timing matters immensely. The laterality of the stroke, whether it is left versus right, seems to matter mostly in the acute and subacute phases, the first few months after the injury.
Why is that?
Well, the brain is reeling, and asymmetric network shock might play a role. But as time goes on, that left versus right effect washes out.
And the second principle?
The second principle is that specific networks trump broad geography. The frontal subcortical circuitry, which encompasses the prefrontal cortex on the surface and dives deep into the basal nuclei in the thalamus, is the fundamental engine of mood regulation.
So it's the whole circuit.
Yes. When a stroke damages any critical node in that circuit, whether it's a massive cortical stroke in the frontal lobe or a tiny lacunar infarct deep in the basal ganglia, the system fails, and the risk of depression skyrockets. It is about the wiring, not just the zip code.
That makes perfect sense. It unifies the conflicting data by focusing on the functional circuit rather than just left versus right.
Exactly.
Now, I want to contrast depression with something that looks very similar on the surface, but is biologically and experientially completely different. Apathy.
This is such an important distinction.
If depression is a malfunction in the brain's emotional pain circuits, what is the apathy circuit? Because as we mentioned earlier, apathy isn't just being profoundly sad.
Right. It is perhaps one of the most vital clinical distinctions the physician can make. Apathy is defined as the absence or profound lack of feeling, emotion, interest, concern, or motivation.
It's just a blank.
A depressed patient is often in deep psychic pain. They feel guilt, they feel sorrow, they might cry. An apathetic patient feels nothing. It is a void.
And do we know where this void originates?
Yes. Through modern neuroimaging and lesion studies, we now have a very clear anatomical substrate for this void. The architecture of apathy lies specifically along the anterior cingulate subcortical circuit.
Let's trace that circuit for the listener. If I'm looking at a map of the brain, what are the stops on this strain line?
It is a fascinating loop. The circuit begins in the cortex, at the anterior cingulate gyrus. This area acts as the brain's error detection and conflict monitoring system. It evaluates the emotional relevance of what is happening around us.
From there, where does it go?
Projections travel to the frontal cortex, where we plan and execute our actions.
So we evaluate an emotional cue and plan an action. Where does the signal go next?
It dives deep into the subcortical structures. The signal hits the ventral striatum. This is incredibly important.
Why the ventral striatum?
The ventral striatum is our primary reward and motivation center. It is bathed in dopamine. When you see something you desire, a piece of chocolate, a loved one, a goal, the ventral striatum lights up and generates the internal drive to say, go get that. It feels rewarding.
Right. It is the engine of desire.
From the ventral striatum, the circuit moves to the ventral pallidum, which acts as an output relay, and finally projects back up to the magnocellular dorsomedial thalamus.
And the thalamus.
The thalamus acts as a grand switchboard, routing the processed information back up to the cortex to complete the loop and initiate the motivated behavior.
So what happens when a vascular event damages this loop? Say a tiny lacunar stroke wipes out a section of the ventral striatum or the thalamus.
The entire circuit is physically unplugged. The brain's motivation engine stalls.
Wow.
Patients with lesions anywhere along the specific pathway, particularly in the basal ganglia, show little to no behavioral response to positive reinforcement. They aren't depressed in the traditional sense. They aren't actively suppressing their joy.
It's gone.
Their brain simply lacks the structural integrity to generate the internal drive to care about anything. The go-get-that signal cannot reach the planning centers.
It is terrifying, but biologically, it is a brilliant illustration of how mechanistically our personalities are built.
It really is.
We've talked extensively about depression, apathy, and the frontal subcortical loops. Let's shift our focus to the right hemisphere. The textbook brings up right hemisphere phenomena, specifically secondary mania and post-stroke psychosis. Now, these are relatively rare presentations post-stroke, aren't they?
They are very rare, occurring in only a small fraction of a percent of stroke survivors.
But in neuropsychiatry, rare anomalies are incredibly valuable. They act as puzzle pieces that help us understand normal brain function by showing us what happens when highly specific systems fail.
Exactly. Post-stroke mania is a perfect example. It is almost exclusively associated with unilateral right hemispheric lesions.
Where specifically?
Specifically, we see it when strokes hit the basocemporal cortex, the orbitofrontal cortex, or the deep subcortical structures connecting to them, like the right thalamus or the right caudate nucleus.
That is highly specific. Why the right side? And more importantly, how does a stroke, which destroys tissue and usually decreases function, cause someone to become manic, hyperactive, and euphoric? You would think brain damage would slow you down, not speed you up.
To understand this paradox, we have to introduce a vital neurophysiological concept called diaskesis.
Diaskesis. Explain how that works.
Diaskesis refers to a sudden loss of function or a change in metabolism in a portion of the brain that is completely intact and healthy, but is connected to a distant area that has been damaged. It is a downstream ripple effect.
Give us an example of how that causes mania.
Well, in post-stroke mania, a patient might have a lesion in the right basotemporal cortex. That dead tissue isn't causing the mania directly, but that lesion causes profound, distant hypometabolic effects in the orbitofrontal cortex.
So the damage in one area shuts off the power to a distant area.
Exactly. The working hypothesis is that these specific right hemispheric lesions effectively remove a vital tonic inhibitory input to the orbitofrontal thalamic circuit.
So the orbitofrontal cortex usually acts as a brake pedal for our emotions and impulses, and the stroke cuts the brake line.
That is exactly it. Without that continuous, steady inhibition from the right hemisphere acting as a brake, and coupled with the post-stroke disruption in biogenic amines we discussed earlier, the limbic system, our primal emotional core, fires completely out of control.
And that looks like mania.
The result is the sudden elation, the pressured speech, the decreased need for sleep, and the grandiosity that we see in secondary mania. The brain is structurally damaged, but functionally overactive.
It is a stunning mechanical failure. And what about post-stroke psychosis? The sudden onset of delusions or auditory and visual hallucinations after a vascular event, where do those originate in the network?
Again, we see a very strong right hemispheric dominance. Post-stroke psychosis is highly associated with lesions in the right lateral prefrontal cortex or lesions in other areas that specifically disrupt connectivity to this right lateral prefrontal region.
Is the lesion alone enough to cause the psychosis?
Actually, no. The lesion alone usually isn't enough to cause full-blown psychosis. The literature indicates there are two other critical synergistic ingredients often present.
What are the compounding factors?
First, patients who develop secondary psychosis tend to have significantly greater underlying subcortical brain atrophy prior to the stroke.
How does that show up?
On a scan, this presents as enlarged ventricles, indicating that the brain tissue has been slowly shrinking over time, perhaps due to chronic silent microvascular disease. Their brain is already vulnerable and operating with reduced cognitive reserve.
So the stroke is the straw that breaks the camel's back. And the second factor?
The second factor is fascinating and heavily debated in terms of causation. Several investigators report a surprisingly high frequency of clinical seizures that start after the brain lesion occurs, but before the onset of the psychotic symptoms.
So it is a perfect storm of pathology. You have pre-existing atrophy weakening the overall network, a strategic vascular hit to the right lateral prefrontal cortex, and then electrical instability in the form of seizures acting as a catalyst, sparking the delusions and hallucinations.
Precisely. It highlights how complex, multifactorial, and dynamic these severe neuropsychiatric presentations are. It is never just a stroke-caused psychosis. It is a specific sequence of structural, atrophic, and electrical failures.
Okay, we have thoroughly mapped the circuits, the wiring, and the biological theories. Let's transition from the textbook neuroscience to the reality of the hospital ward.
That's where it really matters.
Exactly. How does all of this neurobiology actually manifest when a patient is sitting across from you in the clinic? Let's start with the cognitive impact. Vascular cognitive impairment, or VCI?
VCI is an umbrella term. The
Yeah.
DSM-5 outlined a spectrum of impairment here, ranging from mild vascular neurocognitive disorder to major vascular neurocognitive disorder.
And major is what we used to call vascular dementia, right?
Yes. It's important to note that major vascular neurocognitive disorder replaces the older, perhaps more familiar term, vascular dementia.
What separates the mild from the major?
To meet criteria for the major disorder, a patient must demonstrate significant, objectively measurable impairment in cognitive domains, and crucially, this impairment must interfere with their independence in everyday activities.
Like they can't pay their bills or drive safely.
Exactly. They can no longer manage their finances or their medications or safely drive. Furthermore, to tie it to the vascular etiology, these deficits must be temporally related to one or more cerebrovascular events, or they must present as prominent executive dysfunction, things like severe inattentiveness, wildly slowed processing speed, or an inability to plan and sequence tasks.
And the prevalence of this is significant. The textbook mentions an age-standardized prevalence of about 1.6% for vascular dementia in Europe, a number that rises dramatically as the population ages.
Yes, it's very common.
But when looking at the risk factors for VCI, there is a fascinating paradox that caught my eye. We all know that hypertension, high blood pressure, is the undisputed, biggest modifiable risk factor for stroke worldwide. It damages the vessels.
Right.
But the text highlights a specific longitudinal study of 173 patients where something entirely counterintuitive emerged regarding dementia risk.
Yes, that study highlights a vital, highly nuanced clinical reality. While chronic hypertension causes the atherosclerosis and the large strokes in that specific longitudinal cohort, hypotension, abnormally low blood pressure, was actually the most common, powerful risk factor for the progressive development of vascular dementia itself.
Wait, slow down. How does that work? If high blood pressure breaks the pipes, why is low blood pressure causing dementia?
Think back to our metropolis plumbing analogy. If the deep pipes, the tiny penetrating arteries feeding the brain's white matter, are already narrowed, stiffened, and thickened by decades of high blood pressure, they lose their elasticity.
Okay, they get rigid.
Right. Because they are so narrow, you actually need a certain relatively high amount of systemic blood pressure just to physically push the blood through those tight spaces and reach the deepest, most vulnerable parts of the brain.
So the brain adapts to the high pressure just to survive.
Exactly. The autoregulation shifts. If the patient's blood pressure suddenly drops, perhaps due to dehydration, a failing heart, or very commonly because a well-meaning doctor prescribes too high a dose of blood pressure medication, those deep, narrowed regions experience severe hypoperfusion.
The pressure isn't high enough to push the blood through the narrow pipes.
Exactly. Those deep white matter tracts quietly starve of oxygen. Over time, this chronic, silent subcortical ischemia destroys the neural pathways, leading to the slowed processing, apathy, and executive dysfunction that are the absolute hallmarks of vascular dementia.
That is an incredibly delicate clinical tightrope for a physician. You have to lower the pressure to prevent a massive hemorrhagic stroke. But if you lower it too much, you slowly starve the white matter and cause dementia.
It is one of the greatest challenges in geriatric psychiatry and neurology. We will definitely revisit how to manage that in the treatment section.
Let's do that. What were the other risk factors for VCI mentioned?
Other risk factors included smoking, hyperlipidemia, and interestingly, limited formal education.
The education factor is debated, right? Does education build a thicker, more resilient neural network, a cognitive reserve, or does it just correlate with wealthier people who have better access to healthcare and less vascular risk overall?
It is likely a combination of both, but the cognitive reserve hypothesis is very strong. More educated brains seem to find functional workarounds when certain pathways are damaged.
Let's move from cognitive decline to the absolute heavyweight of this chapter, post-stroke depression. We discuss the mechanisms, but give us the sheer scale of PSD in the real world.
The epidemiological numbers are daunting. Pooled prevalence from dozens of robust studies shows that at any given cross-sectional moment, roughly 30% of all stroke survivors are experiencing clinical depression.
30%.
Yes. But if you look longitudinally at the cumulative incidence over a 5-year period following a stroke, it is a staggering 39% to 52%.
Almost half. 1 in 2 stroke survivors will battle a major depressive episode within 5 years. And this isn't just a brief period of feeling a bit down about being in the hospital.
No, it's profound.
The text provides a really powerful clinical vignette that illustrates how destructively this impacts a patient's quality of life. Let's look at the case of the 71-year-old corporate executive.
Yes, this case history is vital because it perfectly encapsulates the profound vocational and social immobilization of PSD, often in patients who look perfectly fine on the outside.
What happened to her?
This was a 71-year-old woman who suffered a thrombosis, a clot in the basilar artery. Thanks to excellent acute care, physically, she recovered remarkably well. Her neurologists and physiotherapists cleared her. She was able to return to her high-level corporate job. Her physicians essentially told her she had dodged a bullet and was physically fine.
But psychologically, the circuitry was damaged.
She was internally devastated. What's crucial to note is that she didn't present like a classic psychiatric patient. She wasn't outwardly tearful. She didn't look classically sad to her colleagues.
But what was she experiencing?
She experienced a complete, crushing loss of interest, concentration, and motivation. She couldn't accomplish simple administrative tasks she used to do in her sleep. She entirely lost her ambition to climb the corporate ladder, experienced severe early morning awakenings, and lost her appetite.
She was physically capable of moving through the world, but the stroke had fundamentally altered her drive and capacity to experience any pleasure or satisfaction.
Yes.
And this invisible suffering is where the danger peaks. The text highlights a stark, terrifying risk of post-stroke suicide.
It is a risk that is often overlooked in busy rehabilitation wards. Suicidal ideation frequently develops shortly after the acute stroke as the reality of the impairment sets in and the biological depression takes hold.
What are the main risk factors for that?
The most important statistically validated risk factors for post-stroke suicide are the presence of PSD itself, a pre-existing mood disorder before the stroke, a prior history of previous strokes, and comorbid cognitive impairment. Clinicians must actively, directly screen for suicidal thoughts. We cannot fall into the trap of assuming they are just naturally adjusting to their new physical reality.
Because, as the 71-year-old corporate woman showed, this is not just an adjustment issue, and more importantly, PSD is highly treatable. The vignette notes she responded dramatically to nortriptyline, a tricyclic antidepressant.
She did. Within months, her energy, concentration, and ambition returned. It proves the depression was a physiological state that could be medically, chemically reversed.
Now let's look at the silent saboteur we mapped out earlier. Apathy. I want to reiterate the distinction because it is so vital. Apathy isn't the presence of bad feelings. It is the absolute absence of any feeling. It is a flat line of the human spirit.
It is a devastating syndrome for families to witness. Apathy is highly prevalent, affecting approximately 35% of patients post-stroke.
That's huge.
And while we know it frequently co-occurs with depression, about 40% of apathetic patients are simultaneously depressed. It frequently occurs entirely on its own. They are distinct neurobiological syndromes.
So they aren't the same thing.
Not at all. The relative risk of depression among apathetic patients is 1.8, meaning they often travel together, but they are absolutely separate entities requiring different diagnostic approaches.
The vignette of the 55-year-old office manager really brings this home. He had a right prefrontal ischemic stroke. Walk us through his presentation.
His presentation was entirely baffling to his family and the nursing staff. He wasn't crying. He didn't express feelings of worthlessness. He wasn't sad. He simply sat in his chair.
What happened when they tried to get him to do rehab?
When the physical therapists arrived, he politely but firmly refused to do his exercises. He told the staff in a flat voice, "I don't have energy now." He felt completely disconnected, disinterested, and emotionally flat.
That's so sad.
The most heartbreaking description came from his daughter, who simply said he had lost his sparkle.
And the clinical prognostic impact of this loss of sparkle is profound, isn't it? Because in stroke recovery, if you don't care, you don't do the arduous, painful work of rehabilitation.
Exactly. This is why apathy is so dangerous. Apathy is actually a significantly stronger predictor of poor functional recovery in activities of daily living, or ADLs, than depression is.
Really? Worse than depression?
Yes. Think about it. If a patient is severely depressed, they might be in emotional agony, but they might still engage in rehab because they feel a sense of guilt or obligation to their family. An apathetic patient simply won't. They lack the biological machinery to care about the outcome.
That makes total sense.
In a one-year longitudinal study, patients in the apathy group demonstrated significantly less recovery in cognition and basic ADLs during the first year after their stroke compared to non-apathetic patients with similar initial deficits. It's a massive, concrete barrier to recovery.
Let's pivot from the total absence of emotion to the explosive, uncontrollable overflow of emotion. We are talking about emotional dysregulation. There are two distinct, fascinating states here: pseudobulbar affect, or PBA, and the catastrophic reaction. Let's start with PBA.
Pseudobulbar affect is a remarkable neurological phenomenon. It was beautifully described by Redvers Ironside in 1956. PBA is characterized by sudden, involuntary, completely uncontrollable displays of laughing or crying.
And the key is that it doesn't match how they feel, right?
Crucially, yes. These outbursts are completely incongruent with the patient's inner emotional state. A minor provocation, like asking them what they had for breakfast, might cause intense, exaggerated, sobbing, weeping.
That must be so confusing for them.
It is. The key diagnostic feature is that the patient will look at you through their tears and say, "I don't feel sad. I don't know why my body is crying."
It is a mechanical misfiring of the expression of emotion, entirely divorced from the feeling itself. What is broken in the brain to cause this?
Historically, neurologists thought it was due to bilateral interruption of descending upper motor neurons. But current functional neuroimaging and lesion analysis point to the partial destruction of raphe-serotonergic neurons in the brainstem, or the severing of their projections to the cortex.
Are there specific pathways involved?
Yes, there is also very strong evidence that critical lesions eliciting PBA are located specifically along the frontopontocerebellar pathways. These pathways coordinate the physical motor acts of laughing and crying.
And the social impact of this condition is just awful. The textbook shares a vignette of a 64-year-old woman who had a right hemispheric stroke. She was having explosive crying episodes 5 to 10 times a day.
A poor woman.
She actually stopped leaving her house, stopped seeing her friends, and isolated herself entirely out of sheer fear of social embarrassment. It's a neurologically induced social phobia. But again, this is highly treatable. She was prescribed nortriptyline, and the crying spells ceased.
It is a tragedy when it goes undiagnosed because the treatment response is often rapid and life-changing.
Now contrast PBA with Kurt Goldstein's concept of the catastrophic reaction. This looks somewhat similar on the surface, but the underlying drive is completely different.
Very different. A catastrophic reaction is a sudden, explosive emotional outburst of intense anger, frustration, depression, refusal, shouting, and swearing.
It sounds, to be blunt, like a severe temper tantrum from an adult. Is it just understandable frustration at being suddenly disabled? Say a patient with severe expressive aphasia who is furiously angry that they cannot communicate their needs.
That was the initial intuitive assumption, but the epidemiological data proves otherwise. Catastrophic reactions are not significantly more frequent among severely aphasic patients compared to non-aphasic patients with similar functional deficits.
So it's not just a psychological response.
No, it is not just a psychological response of a frustrated person.
Huh.
Instead, it is highly linked to the presence of major post-stroke depression, and anatomically, it is specifically associated with anterior subcortical lesions, particularly in the basal ganglia.
So what is the mechanism? Why does a basal ganglia lesion cause a patient to swear and throw things?
It represents a neurophysiological release phenomenon. The deep subcortical damage essentially destroys the normal inhibitory input that travels to the limbic areas of the cortex.
So the brakes are off again.
Exactly. Under normal circumstances, your frontal lobes and basal ganglia suppress extreme emotional outbursts when you encounter a minor frustration. Without that structural cortical braking system, the brain cannot regulate its response. Minor stressors result in explosive, catastrophic emotional outbursts. The filter is physically broken.
I want to touch quickly on a bizarre phenomenon called anosognosia. This concept was introduced by the famous neurologist Joseph Babinski.
Yes, Babinski described a condition where the mind literally ignores or is completely unaware of its own profound physical paralysis.
Which sounds impossible.
It does, but a patient with severe left-sided hemiplegia, completely unable to move their left arm or leg, will casually claim their arm works perfectly fine. In extreme cases, they might even claim the paralyzed arm lying in the bed next to them belongs to someone else.
That's incredible. How common is that?
The prevalence ranges from 20% to 44% in the acute phase of strokes, particularly right hemispheric strokes with complete contralateral motor impairment. Fortunately, as the acute brain swelling goes down, it usually resolves spontaneously within 3 months.
And finally, in this clinical manifestation section, we must discuss anxiety and PTSD. We spend so much time focusing on depression, but anxiety is a massive, crushing burden for stroke survivors.
It is incredibly prevalent. We see a pooled prevalence of 29.3% for anxiety disorders in the first year post-stroke. Generalized anxiety disorder, or GAD, is particularly common.
And does it go away?
That's what's deeply worrying. Its chronicity and stability. Even 3 to 5 years out from a stroke, long after the physical rehab has ended, the prevalence of anxiety remains stubbornly high, hovering around 20%. Anatomically, imaging studies have associated post-stroke anxiety specifically with right frontal cortical infarcts.
The textbook also brings up emerging literature on post-stroke PTSD, post-traumatic stress disorder. They cite an 18% prevalence. Now, this isn't about specific lesion locations disrupting a circuit, is it? This is about the psychological terror of the event itself.
Precisely. A stroke is not just a neurological injury. It is a sudden, life-threatening, intensely terrifying, acute medical emergency. You are suddenly trapped in a failing body, rushed to a hospital surrounded by alarms. It leaves a deep psychological scar independent of where the dead tissue is.
What predicts who gets PTSD?
Predictors for developing post-stroke PTSD include a history of recurrent strokes, which means living in a constant, hypervigilant state of terror, waiting for the next one greater physical disability, and having other severe medical comorbidities.
So we have this terrifying, incredibly complex picture of the brain circuits misfiring apathy, explosive crying, silent dementia, crippling anxiety. But if you are the doctor standing at the foot of the patient's bed, you cannot just admire the intricate neuroanatomy, you have to act.
You absolutely do.
How do you integrate this? How do you predict who is going to fall into these neuropsychiatric traps before they lose months of their life to depression? Let's move into integration and clinical reasoning. We need to start with timelines.
The temporal timeline is a vital diagnostic clue. Post-stroke depression is not a brief, transient adjustment period. Left untreated, a major depressive episode post-stroke has a mean duration of about 9 months, which is an eternity for someone trying to recover physically.
And minor depression.
Minor subsyndromal depression lasts around 3 months. For cognitive decline, the timeline is insidious. An incident stroke leads to an acute, immediate decline in cognitive function, but it also sets off an accelerated and persistent trajectory of cognitive decline over the subsequent years, entirely independent of the patient's pre-stroke cognitive function.
So we know the risks are incredibly high and the duration is long. How can clinicians predict who's going to get hit with PSD? We can't just wait for them to stop eating and stop doing rehab.
We use validated clinical tools, like the Post-Stroke Depression Prediction Scale, developed by Janneke de Man van Ginkel and her colleagues. This allows clinicians to be proactive. If you assess a patient within the very first week after a stroke, you look for specific, weighted factors.
What are the red flags on that scale?
A prior medical history of depression or other psychiatric disorders is the biggest red flag. It carries a massive odds ratio of 7.2. You also look at their cardiovascular history, specifically a history of hypertension or angina, and critically, you look at their immediate physical impairment as measured by the Barthel Index. A key indicator is their inability to dress themselves.
So the prediction model combines their psychiatric history, the chronic state of their blood vessels, and their immediate loss of physical independence.
Exactly. Using that scale, patients who scored in the highest risk category during week 1 had an 82% chance of developing clinical depression by week 6 to 8.
That's a massive predictor.
This is a game changer. It allows the clinician to initiate close monitoring or even prophylactic treatment immediately, rather than waiting for the patient to crash.
I love that proactive approach. And moving from clinical questionnaires to the laboratory, the biomarker frontier, this is where the future of psychiatry lies. What are clinicians looking for in the blood of stroke survivors?
They're looking for early molecular warning systems.
Huh.
The research consistently shows specific derangements in patients who go on to develop PSD compared to those who don't. We see decreased serum levels of BDNF, brain-derived neurotrophic factor.
And what does BDNF do?
BDNF is essentially miracle grow for the brain. It is crucial for neuroplasticity in creating new connections. If BDNF is low, the brain cannot repair the psychological damage.
And what about the information we discussed earlier? Does that show up in a blood draw?
Absolutely. We see elevated early markers of systemic inflammation like C-reactive protein or CRP and ferritin. Pro-inflammatory cytokines, particularly TNF-alpha, are markedly upregulated. We also see neuroendocrine failure, hypercortisolemia, a chronically elevated stress response, and a blunted cortisol awakening response, meaning their circadian rhythm of stress hormones is entirely broken.
It paints a vivid molecular picture of a brain that is profoundly inflamed, chemically stressed, and entirely unable to repair itself. So how do we intervene? What are the treatment paradigms?
The foundational, absolute, non-negotiable principle here is that treating the vascular risk is psychiatric treatment. If you want to protect the mind, you must aggressively protect the blood vessels. You cannot separate the two.
Right.
This means deploying antiplatelet agents like aspirin to prevent secondary ischemic clots from forming. The landmark UKTIA aspirin trial demonstrated up to a 25% reduction in non-fatal strokes or death with consistent aspirin use.
And controlling blood pressure. The textbook mentions a massive Cochrane review of almost 40,000 participants showing a pooled risk ratio of 0.88 for preventing dementia simply by taking a blood pressure lowering agent.
Yes, but as we discussed earlier regarding the hypotension paradox, it requires an incredibly delicate clinical tightrope. You absolutely must treat the hypertension to prevent further white matter ischemia, vessel hardening, and recurrent stroke. However, if your antihypertensive regimen is too aggressive, you risk causing orthostatic hypotension.
That's when the blood pressure drops dangerously low the moment they stand up.
Correct. The brain momentarily loses perfusion. If a frail stroke survivor has orthostatic hypotension, they become dizzy, they fall, they break a hip, which carries massive mortality. Or, chronically, they cause further hypoperfusion to those deep subcortical structures we mentioned, accelerating their vascular dementia. You have to constantly balance vascular protection with functional safety and adequate brain perfusion.
It is truly the art of medicine. And what about pharmacological interventions for the specific neuropsychiatric syndromes once they appear? What is in the toolkit for depression and PBA?
We have excellent, highly effective tools. For post-stroke depression and pseudobulbar affect, antidepressants are the gold standard. Specifically, selective serotonin reuptake inhibitors, or SSRIs, like citalopram or escitalopram, and tricyclics like nortriptyline work wonders.
They treat the PBA too.
They do. They don't just help the mood, they significantly reduce the frequency and severity of the uncontrollable crying episodes in PBA. In fact, there is now an FDA-approved combination drug specifically formulated for PBA called Nudexta, which is an innovative mix of dextromethorphan and quinidine. It specifically targets the sigma-1 receptors and modulates glutamate to stop the bulbar misfiring.
And for apathy. Because we established that apathy is not depression, so I assume SSRIs don't just magically fix the motivation deficit.
You are correct. Antidepressants often fail completely in pure apathy. For apathy, we have to target the dopamine and reward pathways. Stimulants like methylphenidate, as we saw in the vignette of the 55-year-old office manager, can jumpstart the ventral striatum and provide that missing motivation.
Are there any new drugs coming out for that?
There are experimental agents showing significant promise, like neferacetam, a novel GABA receptor agonist, which showed significant efficacy in reducing apathy scores in double-blind trials, though it is not yet FDA approved. There is also exciting research into prevention studies show that administering escitalopram preventatively for a year post-stroke significantly reduced the incidence of new-onset apathy compared to a placebo.
All right, we have covered an immense amount of ground, from historical clinical observations to cutting-edge biomarkers. Let's rapidly distill the core concepts from this deep dive. What are the essential truths the listener needs to walk away with?
First and foremost, cerebrovascular disorders produce profound primary neuropsychiatric symptoms. These are not merely secondary psychological reactions to being ill, they are direct biological results of brain injury.
Second, the clinical picture is dictated by location and network disruption, specifically the delicate frontal subcortical and limbic circuits.
Third, apathy is fundamentally distinct from depression. It has its own unique neural architecture, and it is a massive independent barrier to functional recovery. Clinicians must actively look for it.
Fourth, sudden atypical changes in mood, like a new onset mania in a 65-year-old with zero psychiatric history, or sudden bizarre behavioral shifts should always immediately ring the vascular process alarm bell.
And fifth, treatment must be integrated and holistic. You must aggressively target the underlying vascular risk factors while simultaneously providing targeted, symptomatic pharmacological management for the mood and behavioral changes.
Brilliant. Now, instead of just reading out a quiz, let's put this into practice. I'm going to throw a few rapid-fire clinical curveballs at you based on what we've learned, and you tell me what's happening in their brain.
I'm ready. Let's do it.
Scenario 1. You have a patient who is completely refusing physical therapy. They aren't sad, they aren't crying, they just stare blankly and say they have no drive to move. Which neural circuit is most heavily implicated here?
That is classic post-stroke apathy. The damaged mechanism is the anterior cingulate subcortical circuit. A lesion in this pathway, likely hitting the ventral striatum or pallidum, has physically unplugged the brain's motivational engine.
Spot on. Scenario 2. A 65-year-old stroke survivor begins sobbing uncontrollably in the middle of a mundane conversation. But when you ask her what's wrong, she says she actually feels perfectly fine internally. What is the diagnosis?
The diagnosis is pseudobulbar affect, or PBA. The physical act of crying is entirely incongruent with her inner emotional state. It's a misfiring of the frontopontocerebellar pathways.
Scenario 3. You are evaluating two stroke survivors. One has post-stroke depression, the other has pure post-stroke apathy. Which clinical factor is most uniquely hindered by the apathy?
The recovery of activities of daily living, or ADLs. Apathy destroys the internal motivation required to engage in arduous rehabilitation, making it a stronger predictor of poor functional recovery than depression.
Scenario 4. A colleague argues with you that diagnosing depression after a stroke is pointless because all stroke patients are tired and sad. According to the empirical studies by Paradiso and Cumming, how do you respond?
I would point out that Paradiso and Cumming proved the phenomenological symptoms of post-stroke depression are virtually identical to general major depressive disorder. Both the vegetative and psychological symptom profiles match perfectly, suggesting that depression is a true primary psychiatric syndrome.
Scenario 5. You are called to the ward for a rare case. A stroke survivor is suddenly elated, speaking a mile a minute, and claims they're going to start a billion-dollar company despite having no psychiatric history. Where is the responsible lesion most typically located?
Post-stroke mania is almost exclusively linked to the right hemisphere. Specifically, look for lesions in the basotemporal or orbitofrontal areas, or the subcortical connections, which leads to a loss of tonic inhibition over the limbic system through diaskesis.
Final scenario. A patient is struggling with aphasia during rehab. Suddenly, they explode, swearing, throwing a cup across the room, and shouting in intense frustration. Imaging is most likely to show a lesion in which area?
That is a catastrophic reaction. Imaging will likely show a lesion in the anterior subcortical regions, particularly the basal ganglia. This reaction is a neurophysiological release of emotion due to lost cortical braking, not just psychological frustration.
Excellent. As we wrap up this deep dive, I want to leave you, the listener, with a provocative thought to ponder over the coming days. We spend so much time conceptualizing our personality as this rigid, permanent sum of our memories, our choices, and our soul. But consider the phenomenon of silent strokes, those tiny microscopic vascular lesions deep in the white matter that go entirely unnoticed physically. There is no facial droop, no slurred speech, no rush to the A&E, just a tiny capillary closing off in the dark. How many subtle shifts in a loved one's personality, how much of their slow drift into apathy, their sudden irritability, or their rising anxiety as they age is actually the quiet, invisible rerouting of blood flow shaping the mind? Here are the details of this episode.
Neuropsychiatric aspects of cerebrovascular disorders. Byline. When blood flow shapes the mind, how vascular events redraw cognition, mood, and behavior.